certainly my pleasure to be joining you all this afternoon to talk about Pompe disease. I'm a clinical geneticist at the Anna and Robert H. Lurie Children's Hospital in Chicago and a professor of pediatrics at Northwestern University. And one of my interests throughout my career has been in lysosomal storage diseases, including Pompe disease. So today we're going to really review some recent updates related to Pompe disease. We'll talk about the importance of newborn screening and early detection. We'll discuss some newer and emerging treatment options for the disorder. And at the end, I will share with you some additional tools and resources. So here's our agenda, starting with a brief overview, a little bit about genetics, clinical manifestations, and diagnosis, and then the other topics I described. So just as a review, I'm sure this is familiar to many of you because I suspect most of you are treaters in one way or another of patients with Pompe disease. This is a lysosomal storage disorder. It is also a glycogen storage disease. It is the only one of the glycogen storage disorders that is a lysosomal disorder. It's referred to as glycogen storage disease type 2. Historically, the late onset form has also been referred to in the literature as acid maltase deficiency. And it's an autosomal recessive genetic disorder caused by a deficiency of the enzyme alpha glucosidase. The result of this enzyme deficiency is progressive accumulation of lysosomal glycogen. This primarily affects skeletal and cardiac muscle, but we do see it to some extent in other tissues. The literature suggests that the global prevalence of the disease is about 1 in 40,000, although our newborn screening data suggests it's probably more common than this. And most cases are of the late onset variants, with literature suggests 1/4, but again, newborn screening is changing our view of this. Somewhat less than that are patients with the infantile form. It is pan-ethnic, but African Americans and East Asians appear to be at somewhat higher risk. Although it exhibits a spectrum of severity, as all lysosomal disorders do, it's generally categorized into two groups of patients, those with the infantile onset disease. This is the most severe form that presents clinically before 1 year of age. And indeed, if you look, all infants who are affected with this form of the disorder actually have manifestations at birth, typically have an elevated CK and cardiomegaly even at birth. And then late onset disease, which can present anywhere between the first year of life and the 5th or 6th decade. So very, very broad spectrum of severity, paralleled also by variation in age of onset in the late onset patients. And of course, late onset is a little bit of a misnomer for patients who present in the first year of life. And the major differentiating feature between the infantile and the late onset disease is that we see cardiomyopathy with the infantile patients, and that is not a typical characteristic in late onset disease. The prognosis, of course, depends on the severity of the disease, the age of onset. The very severe infantile onset Pompe disease patients, in the absence of treatment, rarely survive beyond their first birthday, whereas the late onset patients progress much more slowly and can live into late adult life, although there is increased mortality. There are many, many different mutations in the relevant gene, which is the GAA gene, which encodes the alpha glucosidase enzyme, that result in Pompe disease. Missense mutations are the most common, but we also see other mutation types, deletions, nonsense mutations. And the onset and severity of disease correlates with the degree of enzyme deficiency in the body, but this isn't always easy to precisely define in the test tube, which is an artificial system. But we know that the most severe infantile patients, by and large, have null mutations. They make virtually no alpha glucosidase, whereas the patients with late onset disease have a little bit of residual enzyme activity, which spares the heart and causes the disease to be clinically less severe, although again, highly variable. So here you're just seeing a little diagram on the right side of the screen of what happens with lysosomal glycogen in the face of normal GAA activity. It's broken down to glucose, exits the lysosome. But in the absence of GAA, there's progressive accumulation within the lysosome, which is not only structurally a problem, but it causes lysosomal dysfunction and impacts many other cellular mechanisms, autophagy, and so on. So just to drill down a little bit more on the infantile patients, we talked about the severity of the disease and the fact that they have cardiomyopathy. In the pre-newborn screening era, they typically presented at 2 to 3 months of age with symptoms of congestive heart failure, hypotonia, muscle weakness, enlarged tongue, hepatomegaly. They had difficulty with feeding, failed to thrive, and of course, in the absence of treatment, did not survive. You see the very large heart here on the screen in this baby. The patients with later onset Pompe disease have more of a musculoskeletal presentation. So they present with progressive muscle weakness, typically in a limb girdle type distribution. So in the past, many Pompe patients were misdiagnosed as having limb girdle muscular dystrophy. They also have significant respiratory muscle weakness. Diaphragm and respiratory muscles are weak. So as compared with many other neuromuscular disorders, the respiratory symptoms tend to be more severe earlier in the course, or as in comparison with the degree of skeletal muscle weakness overall in Pompe patients than in some of the other disorders. As I mentioned, we don't really see the typical cardiomyopathy that we see in the infantile patients. Occasionally, you may see cardiac hypertrophy, likely related to respiratory symptoms, but it isn't really part of the disease. Some patients do have gastrointestinal manifestations, however. They tend to be thin, they have difficulty maintaining their weight, can have chewing and swallowing difficulties, can have diarrhea, and some abdominal discomfort. And historically, we know there have been long delays in diagnosing late onset Pompe disease because of the insidious presentation, slowly progressive muscle weakness. So kids with the disorder may just be thought of as not being very athletic, kind of clumsy until things progress further. And then they're identified as having frank muscle weakness and get to medical attention. In the Pompe registry, the data gathered on a large group of patients with LOPD suggests that there's up to a 10-year delay historically. I think that's gotten better in recent years with greater awareness and better testing methods, gene panels, and things like this, but still not uncommon to have diagnostic delay. Because of that, and because that we know that particularly with the infantile onset patients, the timing of treatment makes a critical difference in the patient's outcome. We now have newborn screening for Pompe disease. It was added to what's referred to as the recommended uniform screening panel in the US in 2015. This is a list of disorders endorsed by a federal advisory committee and approved by the Secretary of Health and Human Resources as recommended to be included on every state's newborn screening panel. It isn't a mandate, but most states ultimately do fall in line. And you can see looking at the map here on this slide that as of the beginning of this year, most of the states were, every state in red is doing newborn screening for all infants for Pompe disease. And so over 85% of babies in the U.S. are now screened. The big plum that still remains is Texas. It has 10% of the births in the country. They're expected to come online by this coming fall. So that should get us very close to screening every child that's born in the United States. And both IOPD, infantile and late onset Pompe disease, are detected. The primary screen is a measure of the GAA enzyme activity in the dried blood spot that's taken on all babies for the many other disorders for which we do newborn screening. And then additional testing is done once a positive newborn screen is received. The first thing we do when we get a baby who has low GAA activity is we look for evidence of infantile onset disease, because then we need to start treatment immediately, because even a 2-week delay can adversely affect the prognosis. So we get a CK. They all, I would say, have elevated CK at birth, and cardiomegaly typically seen on chest X-ray and ECG, even if they're not overtly clinically symptomatic. So if we don't see that, then of course we're going to proceed to further evaluation with the repeating the enzyme in a peripheral blood sample. If the enzyme activity is confirmed to be low, then we do molecular testing and measure urine hex-4, which is a breakdown product of glycogen, so it's a proxy for substrate accumulation. Frequently our molecular testing is very helpful in confirming that this is late onset Pompe disease. We don't expect it's going to show us infantile, because we would pick that up with the previous testing. But if we have an infantile patient, we certainly want to know what their mutations are. And when we see infantile disease, of course, we start enzyme replacement therapy immediately. Depending on the CRIM status, this is cross-reacting immunologic material, which we can usually determine with the molecular testing. We may need to start immune modulation also at the time that we start enzyme replacement therapy. And even in the CRIM positive babies, we typically start on more modified or less aggressive immune modulation, because we know that there are patients who develop high titer antibodies to the enzyme, and that interferes with efficacy. Now, if we diagnose a baby with LOPD through newborn screening, and this is really 75 to 80% of the positive diagnoses we get, then we monitor closely for symptoms. We don't immediately start treatment at birth, but if we begin to see the onset of symptoms, typically delayed motor development or hypotonia, and this is often paralleled by elevated CK, but we don't typically treat to biomarkers only. Then we start treatment, and we have started some LOPD patients as early as 1 year of age. But many of them, of course, will go for significantly longer before developing any clinical symptoms. But even for these patients, I think there's clear benefit of newborn screening, because at the first sign of symptoms, they will have the opportunity to be treated and won't experience that diagnostic odyssey that was so common in the pre-newborn screening period. Now, once we make a diagnosis of Pompe disease in a child or an adult, there is typically a multisystemic involvement, of course, as we've discussed, and we need a team of providers to provide the optimal care to the patient. So in the case of the infantile patients, of course, cardiology is important because of the cardiomyopathy. We need respiratory support, respiratory function testing. Patients may need oxygen or other respiratory support, CPAP, BiPAP. Our neurologists, of course, very important, and gastroenterologists in some cases, or certainly careful monitoring and attention to the patient's nutrition. And of course, genetic counseling is important for all parents of a child with Pompe disease and for all patients who are diagnosed as having Pompe disease as adults. Geneticists like myself, we're often the treaters with regard to treatments like enzyme replacement therapy, but all of the other players are very important as well. So I've alluded to enzyme replacement therapy because that is our standard of care treatment currently. And we will talk about it in a little bit more detail, both the first enzyme replacement therapy that was approved for Pompe disease, and then several newer products that have just recently been approved that appear to be somewhat more efficacious. But there are other potential therapies in development, and you can see in the cartoon drawing of the cell on this slide, you can see some indicators of what those therapies are. So we have enzyme replacement therapy, which is given intravenously. These are recombinant forms of the human enzyme, which are taken into cells through the mannose-6-phosphate receptor on the cell surface, which targets them to the lysosome. And they are typically enhanced with they have enhanced glycosylation to enable binding to the mannose-6-phosphate receptor. But unfortunately, these are fairly sparse on skeletal muscle. And so they're there, but that has been one thing that I think has limited the efficacy of enzyme replacement therapy in Pompe disease as compared to some of the lysosomal disorders that we treat. Other types of therapy that are in development include forms of substrate reduction therapy, which inhibit the glycogen synthase enzyme that manufactures glycogen in the cell, some of which is taken into the lysosome for degradation. There's a small molecule inhibitor in development, as well as siRNA targeting the glycogen synthase 1, the GIS1 mRNA, to reduce the production of this. And this could be a very nice therapy, I think, and might be something that is efficacious as a monotherapy, but also might be something that we could combine with enzyme replacement therapy, targeting this glycogen accumulation from both directions, reducing input and then increasing degradation by getting the enzyme into the cell. Chaperones have also been looked at to stabilize the mutant enzymes, which have some enzyme activity, and to enable them to get to the lysosome without being rapidly degraded because of misfolding, and to then do some degradation of glycogen. There is also an ERT that's used in combination with miglustat, which is a chaperone that is currently FDA approved and available. Then finally, there are forms of gene therapy in development for Pompe disease, both liver-directed and muscle-directed. The liver-directed therapies being designed to make the liver into a factory for the enzyme, to supply it on a continuous basis into the plasma to get to other tissues like skeletal muscle and heart. And of course, the muscle-directed to really target the tissues primarily involved in the disease. So our current treatment that's been available longest is L-glucosidase alpha. This was one of the earliest treatments approved for a lysosomal disease. It was approved in 2006 for patients with Pompe disease. So we now have close to 20 years experience with it. And what we know about it is that it is very efficacious in patients with infantile onset Pompe disease in improving cardiac function, as long as we don't have the development of high sustained antibody titers, immunologic assault. So it's very good for the heart, very efficacious for the heart. It's not as efficacious for the skeletal muscle, but we do see improvements in mobility and development and muscle tone and strength for the first 1 to 2 years of treatment in both the infantile patients and the late onset patients, and also in pulmonary function. And but we don't make them normal. We don't make them strong. We don't give them normal muscle strength. And children with IOPD or children who present early with LOPD still develop complications like neuromuscular scoliosis. And the adult patients very often will have some improvement in mobility and function for a couple years, but then a variable period of stability and followed by a slow decline. So it's been an improvement in treatment for Pompe disease without a doubt, very much so for the infantile, but for our more common late onset patients, certainly it's beneficial treatment, but not the greatest. I mean, we do need more because it certainly doesn't completely address the signs and symptoms of the disease. So that gave rise to the development of two newer forms of enzyme replacement therapy. One, aval glucosidase alpha, which was approved in 2021, just a little over 2 years ago. It was approved for patients with late onset Pompe disease, at least 1 year of age. So essentially all of our LOPD patients. They do not have a label yet for infantile onset Pompe disease. And this was studied in a clinical trial of patients with LOPD. I'll show you some of the data in just a moment. But basically, this is an enzyme that has enhanced glycosylation. So it's trying to throw on more of these mannose-6-phosphate residues to allow greater utilization of the sparse receptors on the skeletal muscle surface to really pull the enzyme into the muscle cell. And then the more recent approval was for cipaglucosidase alpha, which is given in conjunction with miglustat, a chaperone, which is designed to improve the half-life in the circulation and may also stabilize the enzyme within the cell to an extent. And this has an indication for adults with LOPD who are not improving on their current ERT. And this has to do with what was shown really in the clinical trial data. Only adults were studied, which is why this is limited to adults. And then the efficacy they were able to show was in patients who switched from another therapy, whereas in naive patients, you know, they had less data. So we'll look a little bit at that also. But so we now have three therapies currently on the market, three forms of enzyme replacement therapy. The glucosidase alpha, the first one, is probably not going to be marketed in the long run because the aval glucosidase is made by the same company. It's their new and improved product, and I think these are the two that we'll be using in most of our patients moving forward. So just to show you a little bit of the data from the COMET trial, this was the phase 3 trial for the Sanofi product, the aval glucosidase alpha. And what you see here graphed is the mean change in FVC, forced vital capacity, from baseline to week 145. The patient, they took naive patients and randomized them to receive either the new therapy in blue or the traditional L-glucosidase alpha, our old ERT. Then you can see the increase in percent predicted FVC, upright FVC over time in the two groups. There was a little bit of increase with the older product, a greater increase here. And this was the primary endpoint of their trial. They were able to show non-inferiority. They were not able to prove superiority. And an interesting element of this data set is that these patients performed so poorly, much more poorly than in the original clinical trial of this product. So it made the newer product look better. The L-glucosidase alpha patients, in previous trials had much more significant improvements. So I think it's just a function of small patient numbers in a rare disease, but certainly it suggests that the newer drug is at least a little bit better. And this was maintained over time. When these patients were switched to the newer drug, there's a little bit of bump up in FVC, but then it came back down again, and ultimately they met here together, but a little hard to interpret some of the elements of these data, I think. Here you see the same thing for 6-minute walk distance, which is what has historically been used in Pompe trials to look at mobility. And again, you see a little bit of difference between the newer drug, the aval glucosidase, and the old drug, the L-glucosidase in pink. And then when they are switched, when the old drug is switched over to the newer one, we really don't get much improvement in this group. So in the end, these patients did better, but it's a little unclear why these patients didn't do better when they were switched over. So the data are suggestive that it's a little bit better, but probably not the solution to all of our problems. Now here we see some of the data from the Propel trial, which is for the third drug. This was a trial where they used both patients on existing therapy, enzyme replacement therapy, and some naive patients. And in the overall population, combining all of them, they did see a significantly better change in the 6-minute walk test distance with the glucosidase alpha combined with miglustat compared with the L-glucosidase, the standard of care therapy. And the same thing with sitting FVC in this case. A little bit of decline in the with the new therapy, greater decline with the traditional therapy. So a difference between the two, suggesting that the newer drug, again, is somewhat better. When they took out the naive patients and looked only at the ones that have been previously treated with ERT, which was typically the L-glucosidase alpha, of course, you can see that those who stayed on that therapy did significantly more poorly than the ones who were switched to the glucosidase, where you saw a bump in 6-minute walk and an improvement, a slight improvement as compared to deterioration in FVC. And this is why really they got a label for the ERT experience, because if they looked at the naive patients separately, really did not see that difference. In both trials, there were some biomarker analyses. Also, here in the Propel trial, we see a significant decline in the urine GLUC4, which is similar to the urine hex4 concentration, again, a proxy for glycogen accumulation. In the ERT experienced, even though they'd been on therapy with traditional ERT for several years, they had a very nice further decline in their urine hex4 on treatment. So those are our newer drugs, and these are some of the ones that are currently in the pipeline. And of course, you can get more information about any of these by going to clinicaltrials.gov. But we have the glycogen synthase inhibitor, from Maze Therapeutics. This is an oral drug. The preclinical data on this look really excellent, and it has been tested in healthy volunteers and no significant safety signals seen. So I think this would be a very nice drug to see come into the clinic. We don't have any data yet in patients with Pompe disease, but they were able to see a reduction in glycogen levels in the healthy volunteers, both in muscle and in mononuclear cells. And then Aerotherapeutics has the siRNA that is designed to reduce synthesis of the GIS1 enzyme. They also have nice data in the preclinical setting and are currently studying this in healthy volunteers. And then the gene therapies that I mentioned, 2 liver-directed gene therapies from Spark Therapeutics and Asclepios, and then the muscle-directed AAV. These are all AAV mediated gene deliveries from Astellas Gene Therapies. These clinical trials are ongoing, and perhaps some of you are even participating in some of these. Okay, so to summarize what we've been discussing, we've seen that newborn screening for Pompe disease provides an opportunity for early treatment initiation and for improving the outcome of that previously very devastating disorder. Of course, that improved outcome would not be possible without the therapies that we now have available through enzyme replacement therapy. And those disease-modifying therapies, at least in one form, have been available for Pompe disease since 2006. But now we have 2 newly approved forms of enzyme replacement therapy, which have shown enhanced efficacy with no additional safety issues. And we have other therapies in the pipeline which offer the promise for additional improvement in the outcome of the disorder. As far as resources are concerned, if you're looking for additional information, we do have published management guidelines in the literature. They date back to the time of the initial approval of the initial ERT. We may see some updates coming in these, but certainly they still are helpful in patient management. There are a number of disease organizations, in addition, of course, to the MDA, which is sponsoring this webinar, but we also have some other organizations, such as the International Pompe Association or the Association for Glycogen Storage Disease, that can provide information to patients and providers and provide support. And the National Organization for Rare Disorders also, which doesn't appear here, but is another one that is very helpful with rare disease. So with that, I'd like to thank you for participating today and for your attention.